morning, everyone. I hope you can hear me.
Yeah.
My name is Pui San. I'm a sport medicine physician and academician at UM, and I am glad today, this morning, to introduce my esteemed colleague, Associated Prof. Goh Siew Lee. She herself is a sports medicine physician and academician at University Malaya with an interest in MSK medicine, biomechanics, knee osteoarthritis, and evidence synthesis. Her work bridges ethical clinical practice, research, and teaching with interest in network meta-analysis and clinician-friendly interpretation of research evidence. So join me in welcoming her, and Prof. Goh, the platform is all yours.
Thanks, Pisan. Can you see my slide?
Yes, I can see your slides.
Okay, great. Okay, that's good. Okay. Good morning, everyone. Thanks for joining me today for the CME. I prepared a short presentation or a short introduction to something I felt that we should be all looking forward to and try to strive to elevate our standard in evidence synthesis. So it's something known as network meta-analysis. And I will do a little bit of introduction to Bayesian thinking as well, which is often associated with network meta-analysis. So why is this why is it that I say that network meta-analysis would elevate our evidence synthesis standard? As we all know, there are too many competing treatment options that we always face in a daily situation, where we have options of different types of medication, different types of injections, different type of therapies. That makes our decision making very complicated and challenging. We are often faced with the question of which is better and which is the best. Conventionally, we would be performing a method of evidence synthesis called meta-analysis. The conventional way of doing this is we compare two treatments, basically maybe exercise with a placebo or exercise with some painkillers for certain conditions. So through this method, we can only do two comparisons, which is A and B. We will perform a clinical trial to study treatment A in a certain group and treatment B in another group and see whether they have any difference in their response. And this is how a meta-analysis would look like. At the end of the analysis, we will look for this little blue diamond here. And if the diamond falls to one side of the graph, it will indicate which treatment would be the best. But however, we have got so many treatment nowadays. How do we decide? Can we just do the usual comparison of A, B, C, C, D? It will become a very tedious and iterative process. That's why network meta-analysis was introduced, because it can simultaneously compare more than two treatments. It can be 3, it can be 4, it can be 5. Okay, as long as the treatments would be connected through some direct studies. I will elaborate on that later. This is not a new technique. It has been in existence in medical literature since 2003. So one of the first work involves a first-line antihypertensive published in JAMA. It has been estimated that the number of NMA would increase exponentially. In 2020, the number was expected to be 600. However, a recent publication looking into the bibliography of network meta-analysis estimate that we have got about 10,000 publications to date since the first appearance of NMA in 2003. As you can see in this histogram, most of the studies are not, I would say, not from Southeast Asia, mainly concentrated in the Western countries and also China as an Asian representative. And there have been extensive network throughout the globe on this analysis technique. So it's kind of a, I would say, established and well-accepted approach. So we should also try to get ourselves more familiarized with this new technique. The reason I will explain later. Probably there is a poor understanding or awareness among the researchers themselves, because they may look at the model as very complicated. However, the model or NMA is actually built on very simple and intuitive elementary reasoning. I will elaborate what what I would like to convey through a simple example about height. Assuming I'm a basketball coach and I have 3 players in my team, A, B, and C, if they tell me that their heights in relative to each other would be 10 cm difference apart, meaning A is taller than B, B is taller than C, all by 10 centimeters. So through this information, this data, we can infer that A would be the tallest player, and his height is actually 20 centimeters different from C, and C would be the shortest, right? Therefore, A and B would be a direct comparison, because we know A has been compared to B and B has been compared to C. So these are direct comparison. When we get the information about A and C, it's actually through indirect comparison. And this network can be extended again. For example, if someone says that a new staff or a new student has now enrolled in university, and he is 10 cm taller than A. Assuming C is the shortest person I will recruit or I will accept into my team, I would definitely want to recruit D into my team as a player, because through the information that D is taller than A, I would assume that he is actually 30 centimeters taller than C, which is the minimum height I would accept. So this elaborate how the connected individuals or the height of individuals can be relatively calculated even though they have not been standing side by side. This is how network meta-analysis work. Therefore, it's actually very simple in concept. Okay, I hope it's straightforward for understanding. Excuse me. To summarize, I would like to say there are 3 main advantages of using network meta-analysis. First, as I've elaborated, it gives estimation without a need for direct trials. So if you have got trials of A versus B, A versus C, we do not need to do additional trials for B versus D directly to estimate the effect. What is C like compared to B? So this is one advantage. The other advantage is that as I mentioned, we could include more than 2 treatments into the model, whereby we have if you have more than 2 competing treatments, you don't really know which one is better, or you like to know how they rank in relation to each other, we could be better off using network meta-analysis than a conventional, whereby you do a different A, B, C, and C, D meta-analysis separately. I will show you how the result will look like if you were to use a network meta-analysis approach. The other would be to improve the estimate, the precision of the estimate that we obtain. In the example given just now about the height, we know that DC is 30 centimeters difference. However, if I decided to put them together, but when they meet, I realized that probably their height through direct measurement is only maybe 28. Therefore, I would revise or maybe adjust my estimate or adjust my measurement. I would say they are just maybe 29 centimeters difference instead of 30 centimeters. So this is what I mean by the direct and indirect can actually counter check each other and give you a better precision in estimation. So the frequently asked question when I recommend an NMA, the question I often being asked is, but they use indirect evidence. Is it reliable? Is it trustworthy? Is it accurate? So I'd like to go back to the example of the height. When we accept the maths behind the height analogy, I think we should also accept the maths behind the NMA. The reason for the question, I assume, is because they have got this heterogeneity in study in the back of their head. Therefore, they are questioning whether the indirect is accurate. However, for height, there could also be some errors in measurement. For example, the data collection wasn't done in the proper way, so the data may not be comparable anyway. So the bottom line is, excuse me. So the bottom line is, we should observe some assumption. We must make sure the assumption exists when we perform NMA. First, the assumption of homogeneity, whereby the study of AC and AB and BC should all be homogeneous. AC trial, in this example in the slide, shows that they use patients of the same, I would say maybe disease severity, or probably same population, same gender distribution probably for AC, and AB uses another set of patients, probably in another country or different set of disease severity. So AC itself can be pooled if you're doing meta-analysis. AB trial itself can be pooled if you're doing the AB meta-analysis. However, if you're doing NMA, the AC, AB, and BC needs to be all homogeneous. It needs to be using the same population, same disease severity, same gender distribution, for example, in order for the maths to work. And I hope it's clear that homogeneity refers to the AC study homogeneity, whereas transitivity refers to the whole network homogeneity. The other thing we need to also check is for consistency of the network. In this consistency, what it means is, for example, that I mentioned, if you put D and C together, they actually do not measure to 30 centimeters. Maybe there's a bit of error that's 28, or it could be 32, 31. So you will probably have to statistically evaluate whether this difference is significant or not. So there's a way for the software to estimate if this difference is significant, and this is how we ensure or convince the readers that our network is sound, because the consistency has been is observed. I mean, it is preserved. So if we have no issues with meta-analysis itself, we should also technically accept the concept of network meta-analysis, because they use the same assumptions of homogeneity throughout their approach. Oops. Okay. In case I have not been able to convince you that network meta-analysis gives you better estimate of your results, you can actually perform network meta-analysis, but just use the direct evidence that they produce. I am showing an example of a statement, and you can link them. As long as you can link them together, you can simultaneously perform a meta-analysis of the four, and the output would show you what is the direct comparison between each pair. So this is 1, 2, 3, 4. Each pair will have their comparison, and they will give you a direct estimate whereby, like for RT versus CT plus RT, this is the direct negative 0.02, implies that this evidence is generated without considering the indirect influence. if you were to perform the meta-analysis using conventional method, this would be the results you get anyway. So I hope you can see how efficient it is if you just do data collection for all the treatment, and you can just use the direct evidence if you're not convinced of the indirect evidence. And furthermore, they will also separately report the direct and indirect estimate and provide you with the network, meaning the adjusted or the estimate that has been harmonized using the direct and indirect evidence. And from here, you can probably, hopefully you will be more happy to consider whether you would trust the mixed evidence given, because it has been adjusted or considered using direct, and it has been calculated using two methods, meaning the direct and indirect methods. Okay, that's basically the fundamental concept about NMA. The other thing I would like to talk about or touch on is the Bayesian thinking, because most NMA, or I would say many Bayesian statistics has been linked to NMA analysis. The reason being, during the development of NMA, Bayesian approach was more flexible. It's a type of statistics used by more advanced software that allows you to change the model, to add information, and to obtain a more precise estimate. So what is Bayesian actually? Bayesian it's a type of reasoning or probability conditional. It's a conditional probability that you use to evaluate whether which treatment is better or what is the effect size of each treatment. For example, you have got a patient history risk factors, and then you have but if you add information from examination, from imaging, and from the lab works that you obtain, then you will probably get more confidence in the final diagnosis that you're going to make. So this is how Bayesian is reflected in our daily work. Bayesian starts off with a prior probability, meaning what we already know, and we add new evidence, and it comes up with the updated estimate. So in the context of NMA, I'll probably put it this way. You know about the direct evidence as a prior information. You know what direct evidence say, and then you add new evidence from the indirect, and you get the updated estimate. However, you can also get information that is outside of the model. For example, you will say from previous study or from previous meta-analysis, it has been found that AB is of certain effect size. You can also incorporate into the model for it to calculate the new estimate. So it is more flexible in Bayesian. As to which is better, because with the new software and new, I would say, advances in our statistical packages, we are now also able to do NMA through frequencies. So there is actually not a question of which is better, but if you are using, if you are doing NMA without a need to include prior information, frequencies method would be sufficient. Just a bit of background as to how this thinking is different. For a frequencies approach, the question would be, how unusual would this observation be if there are no true difference between the two treatments? If I were to give a set of new exercise to a group of participants, and the participants who got this new exercise were able to, after the intervention, were able to probably leave a car without assistance. So since the outcome is so bizarre, I would say that the treatment has worked. However, for Bayesian approach, the probability calculation will be a bit different, because you might say, okay, knowing that some population can actually leave a car without using this exercise, without undergoing this exercise, calculate the new probability that this exercise actually work. Therefore, the Bayesian approach is actually more powerful if you have a lot of information to incorporate and a lot of uncertainty to factor into your estimate. However, it's complicated, so you will probably need statistician assistance. Okay. So the gist of this presentation is to say, if we can go for network meta-analysis and combine it with the Bayesian thinking, I think we could produce better evidence for our clinical practice to be more useful and pragmatic in our conclusion. I think that's all I would like to highlight. Here I have got a few, maybe some questions that I often encounter when I talk about NMA. I'll leave it to you to go through if you are interested. But at the same time, we will take some questions if there are any. Pui San, is any question or not?
So far, there are no questions. Anyway, thank you, Prof. Go, for this insightful and very interesting talk. I'm still trying to wrap my head around network meta-analysis.
Oh, really? Yeah. Okay. What is it that you don't understand?
I'm still trying to. But so far, there's no questions. But thank you for asking your own questions. Anyway, if there are no questions, everyone online right now, don't forget to fill up the Google form, because unfortunately we do not have CPT approval for this yet lah.
Okay. So in case I'm
Thank you
interested,
so much,
this
Prof.
is a resource. Okay. Welcome. Thanks for moderating, Pui San.
Problem. Thank you everyone for joining us.